All right, good morning, everybody. Thank you for being here. My name is Mazen Abu Fadel. I'm from the University of Oklahoma. Dr. Tony Das has been pulled to another live session, so he's not going to be with us today. So this is the Peripheral Channels Challenging Case Competition Semifinals 1. After this, after the presentations today, the panel, myself, will hopefully select 2 presentations to go forward to the finals, which is tomorrow. And there's going to be 2 presentations from the next sessions that will go forward. I would like to just take a minute and let the panel introduce themselves, name and where they're from, and we'll go ahead and get started after that.
I'm Faisal Latif from the University of Oklahoma.
I'm Charlene Tai from UT Southwestern and the Dallas VA.
I'm Rose Lamari. I'm also from the Dallas VA.
Martin Sandro from University of Arizona.
Perfect. Well, thank you, everybody. Thank you for being here. So we'll go ahead and get started with the first presentation. So the first presentation is on IVC stenting, Dr. Ahmed Elsakka. Just want to remind everybody, when you're presenting, just make sure you also take the time into consideration. All these will be looked at. We don't want the presentations to go way more than the time allotted and all this. So thank you.
Yes.
Go ahead.
Good morning, everybody. I am Ahmed Elsakka, Interventional Radiology Fellow from Cairo, Egypt. So my case is IVC stenting case. Our patient is a 36 years old male with a history of thymus gland mass and metastatic hepatomegaly, presented to us with bilateral lower limbs and lower anterior abdominal wall edema. As we see here, that's MRI T2 images. It shows massive hepatomegaly at the lower edge of the liver is inside the pelvis, and multiple metastatic liver lesions and anterior abdominal wall edema. So that's the MRV here. It shows severe compression of the hepatic and the infrahepatic IVC by the massive hepatomegaly and multiple metastatic liver lesions. So our labs, the bilirubin is within normal limits. The liver functions, the ST, ALT around 30s. INR is 1.2. Hemoglobin is 10.8. But the creat is slightly elevated, it's 1.6. So our plan is to do IVC venography with pressure gradient measurement with possibility of balloon angioplasty. And if it's not working, you are going for stenting. So that's the IVC venography. It shows severe compression of the IVC affecting a very long segment. As you can see here, this is a very long segment affected by compression from the massive hepatomegaly and multiple metastatic liver lesions. So we are going to do balloon angioplasty using 16 millimeter balloon, and then we are measuring the pressure gradient between the right atrium and the right iliac vein. Here, as you can see here, we are doing 16 millimeter balloon angioplasty. After that, we are measuring the pressure gradient, and it was 10 millimeter mercury. As the pressure gradient, the pressure in the right atrium is 1 millimeter mercury. The pressure in the right iliac vein is 12 millimeter mercury, so the pressure gradient is 10 millimeter mercury. After that, the lower limbs and the lower anterior abdominal wall edema significantly regressed, but unfortunately, the symptoms started to return again. So our decision is to do IVC stenting. So that's the stent here. We are using wall stent, 14 millimeter, and we are doing also stent balloon angioplasty. As you can see here, the balloon inside the stent to maximize the maximum size of our stent. After that, we are doing another venography, and there is a still residual compressed segment in the lower portion of the IVC. So our decision here is to do another stent. So we are using another stent, which is ball stent, 16 millimeter, and after that, we are measuring the pressure gradient, and the pressure gradient is 10 millimeter mercury. So the pressure gradient before doing anything is around 24 millimeter mercury, and after doing 2 stents in the IVC, the pressure gradient now is 10 millimeter mercury. So the follow-up 3 days after the procedures, the lower limbs and lower anterior abdominal wall edema improved steadily, and the patient is vitally stable. So thank you so much.
Thank you. So let me start by, great case. Let me start by asking a few questions. So did the patient present just with edema, or did he have phlegmasia in his lower extremities? Was there like pain, any hemodynamically, like were there good pulses, good perfusion of the lower extremities, or was it only edema?
Yeah, only edema.
Only edema. And the other thing, do you know from the MRV whether this was tumor invading the IVC, or was it just compressing without invasion? Because some people would, of course you have the renal veins there, but would advocate to do covered stent if there was invasion of tumor. Do you recall if it was invasion or just external compression?
Yeah, it appears from the MRV, it's just compression. Even from the venography, it's just compression from outside.
And here you covered the renal veins with the stents, right?
Yeah, yes, we are covering the renal veins. You see there is a gap between the both stent, but this gap is, some people, some authors just describing using a stent inside the stent, just for crossing. But unfortunately in our institution there is the all sizes not available. So at this case we are using 16 millimeter by 60 millimeter. We can use more long stent to crossing, but it's not available. So we are using 2 stent, doing a very short gap between the 2 stent to cover the whole IVC.
This was IVUS guided, do you remember? Intravascular ultrasound?
No, it's not. We don't have IVUS, but there is 3 measurements for sizing of the stent.
Perfect.
The first standard is roughly estimate as the IVC is from 12 millimeter to 17 millimeter. So we can use just, if we are using 16 to 18 millimeter is perfect for IVC. And the right iliac vein, we can use 16 millimeter. We can use another option, which is CT angiography. But unfortunately, it gives us a higher estimate for the actual IVC diameter.
Yeah, and with the compression, it's not going to help because there's external compression. Any thoughts from the panel? Questions?
So I've been involved in cases using both single stent as well as double barrel. Anybody else has a preference, or is it just a matter of what sizes are available, or any different approach?
Most of the IVC stenting I've done has been for iliac vein issues, in which case we tend to oversize a fair amount, mostly because the dreaded complication of the embolization of the stent up into the heart. So can you just discuss how you just chose to oversize this? Because usually we are oversizing pretty aggressively, at least for the iliac veins.
Yeah, exactly. So, as you said, some authors using oversizing by 1 or 2 millimeter. Some authors not doing this. So at this case, the whole IVC is compressed. So we don't have any idea what's the normal diameter of the IVC. So the whole IVC is compressed. So in this case, we are just roughly estimate we are using 16 millimeter balloon, and then measuring the pressure. The pressure is going down, and we also got a very good angiographic result. So as the pressure is a reliable sign for success of the angioplasty. And at this case, the balloon is 16 millimeter, so are going to stent 16 millimeter or just 1 or 2 above 16, so 18 would be perfect.
Yeah, I think in your case, the sizing, as long as you have a good size, is not going to matter that much because of the external compression. And this obviously was like a palliative procedure, right?
Exactly.
The patient, unfortunately, had very bad metastatic cancer. The MRI didn't look so good. So this was palliative. It's unlikely this cancer is going to go away. But just to make a comment, you have a good point, because when we're doing SVCs, IVCs, and iliacs, post-constriction, the vein is dilated because the pressures are higher. So if you do IVUS and you size it, you can get an appropriate size. If the stent is going to be starting from above, and the vein happens to be bigger from above, and it's under-expanded because there's not enough flow, then you want to oversize as much as possible. And that's why sometimes we put 20, 22 in the IVC or SVC. Perfect. Well, thank you very much. Any other questions from the audience before we let him go? Perfect. Thank you.
Thank you, sir.
Thank you. All right, we'll move on. second case to be presented today is May-Turner syndrome with IVC thrombosis, pulmonary embolism, and iliac vein stenting from Ashley Stewart.